academic channel. This is the clinical posting series where we talk about everything we encounter in the clinic and everything we think you should learn about. Today's episode, we'll be talking about Duchenne Muscular Dystrophy, abbreviated as DMD. We'll talk about what it is, the population it affects the most, its clinical presentation, the physiotherapy assessment we carry out, the outcome measures for it, and the treatment approaches. We'll also touch on differential diagnosis, precautions during treatment, prognostic evaluation, and also any questions that you might have. So prepare your questions, drop them in the comment section, and let's go on. Duchenne muscular dystrophy is an X-linked genetic disorder that leads to progressive muscle weakness due to a mutation of the dystrophin gene. So the dystrophin gene is a gene that produces the protein that makes our muscles stable and strong. And when there isn't enough dystrophin gene in the body, this leads to the muscle fibers being broken down. And over time, this leads to muscle weakness and difficulty with movement and posture. It usually starts from the lower limb, it moves to the upper limb, then it moves to the trunk muscles, the heart muscles, the breathing muscles. And this is the deadly stage because when it affects the heart muscles and the breathing muscles, it leads to issues and complications that affect breathing and the heart function, which can lead to talking about its epidemiology. It is a childhood disease which is more common in the male gender, usually between the ages of 2 and 5 years. So, in females as well, it occurs. However, it usually occurs with pre-existing genetic conditions such as the Turner syndrome. So, in every one out of 3,500 males, you find the Duchenne muscular dystrophy. Moving on to the clinical presentation for Duchenne muscular dystrophy. So one very common clinical presentation is delayed motor milestones. So this child walks later than their peers. So probably their peers are already walking by 1 year old, and then they are taking like 2 years to actually walk and learn to walk. So delayed motor milestones. Another is regression of motor milestones. So this child is already walking, but then you see them having issues with balance, issues with their gait. That's like regression, like how they were when they were learning to walk. Then also the goer sign. So usually when a child is on the floor and they want to rise from the floor, they usually just pull up and stand up. But for a child with Duchenne muscular dystrophy, they push on their body when they are trying to stand from the floor, and this is because there is weakness of their hip and their thigh muscles. This leads to them not being able to contract and rise up from the floor. Another common clinical presentation is a pseudo hypertrophy of the calf muscles. So the calf muscles appears bulky, like they are strong, however they are not. This is because there is fat and fibrous tissue deposition in these calves. In the calves, so this leads to it looking bulky, which is known as pseudo hypertrophy. Also, children with DMD are frequent falls and they have difficulty climbing stairs, they have difficulty walking, and difficulty. What are the assessments you carry out for a child with DMD? So, firstly, assessment always starts with observation. You observe them as they come into your clinical cubicle. You observe the way they are walking. You observe their posture. You observe do they look fatigued just by walking or stuff like that. So you observe observation. Moving on is history taking. So you take their history. You ask your parents, okay, what was the onset of the symptoms? How did they start? And how have they progressed over time? That will give you an idea of, okay, this is Duchenne's muscular dystrophy. Also, you have asked for their family history. Is there a family history of a genetic disorder like that? Do their first cousins or first relatives have such conditions? That would also give you an idea. Then moving on, we also have physical examinations. So you examine the patient, you examine their muscle strength majorly. You examine for contractures. Do they have contractures? Usually at the Achilles tendon, the TA. You also check for the hip, the range of hip flexion and knee flexion as well. You assess that as well. Also, you assess them for the time they take to carry out functional activities. How long does it take them to climb stairs? How long does it take them to walk a 10-meter distance? How long does it take them to fatigue after activity? So the functional tests also includes how do they walk, you check their gait. So this is actually the observational assessment. You observe their gait. Usually children with AMD would have like a waddling gait or an equinal gait where they are walking on their toes. So you check for waggling gait, you check for equinal gait. You also check for scoliosis. You check if there is any presentation of scoliosis as the assessment. Then another assessment you can do is for their respiratory function. So you can do respiratory function tests to see, okay, how much are they respiring, how hard, how difficult is respiration for them, and also cardiac function tests as well can be undertaken. Then also tests, laboratory tests. You can do a genetic test to see if there's absence of the dystrophin gene. There is also a check for the serum creatine kinase, which assesses if the creatine kinase is high. So that would also give you an idea for your assessment. So moving on to the outcome measures for DMD. So the outcome measures that are used include the North Star ambulatory assessment, which assesses the ambulatory function. Also, we do the 6 minute walk test, which assesses the endurance capacity of the child. Also, you can do the time taken to rise from the floor and also the time taken to climb 4 stairs. There is also the Vignos functioning test scale, the Vignos functioning. Moving on to the treatment for DMD. So, firstly, what are the goals that we are trying to achieve for a child with DMD? Firstly, physiotherapy for DMD. Apart from physiotherapy, currently in the world, there's actually no treatment or curative factor for DMD. However, there is a multidisciplinary approach to preservation of life and ensuring optimum quality of life throughout the progression of the disease. So, physiotherapy goals include to maintain ambulatory function as much as possible, to maintain as much muscle strength as possible, and endurance as well. Also, pain relief, want to ensure this child is not living their lives having pain. Then also their breathing function, want to ensure their breathing function as well is optimized. Then we want to ensure they are able to walk around and socialize in their community without restrictions. And this is where we come in with ambulatory aid. So, treatment modalities that we use, firstly, muscle strengthening. We strengthen their muscles. We teach them endurance techniques. So we have like ergometric training, treadmill training, and all. Then we also encourage walking in the house, walking around the house, and not just sitting, because children with DMD are predisposed to to becoming obese because of their reduced physical activity. Then we also help to stretch, sorry, we help to stretch their muscles because they're also prone to contractures. So we stretch and we also do range of motion exercises to improve the range of motion at their joints. Then for children with DMD, we also perform the breathing exercises. So we do deep breathing exercises to ensure that their lung functionality is up to par. We have pain relief. Yeah, for children with DMD as well, we also help them with pain relief. We ensure that they do not feel pain, and we can use each therapy to achieve this pain relief um goal. So, for children with DMD as well, to increase their ambulatory function in the community and ensuring that they do not fatigue easily, we recommend ambulatory aids like wheelchair crutches, and Zimmer's frame or walking frame for them to be able to perform social activities without restriction and still maintain the strength and endurance. Also, for a child with DMD, we do a bit of community and household modifications. So we ensure that the path he walks to school is clear, his school environment, his other social guidance environment are well suited for him. We advocate for the use of ramps because he might be using a wheelchair. So advocate for the use of ramps in the community so that these children can easily walk around and be free in the community. To take and things to actually avoid during treatment. First is over fatiguing exercise because this child is having their muscle fibers being broken down over time. You don't want to fatigue them because normally, as a matter of fact, they're actually fatigued easily. So you don't want to over give them over fatiguing exercises. Then you prevent resistance exercises as well. Of course, we want to strengthen their muscles, but more of what we are working towards is endurance, ensuring that these muscles can actually carry them through their normal daily living. So you do not want to do resistance and increase the progression of the disease. Then also we do not want to do isometric exercises. Isometric exercises as well, just like resistance exercises, increase the progression of the disease. So those are the things we avoid during treatment. And what is the differential diagnosis for DMD? There are a few differential diagnoses. First is the Becker's dystrophy, muscle dystrophy. This is also like the Duchenne muscular dystrophy, but then the age of onset differs and the progression as well differs. Also, polymyositis is another differential diagnosis. Any neurological condition that causes muscle weakness is also a differential diagnosis. So, let's all have your questions and we'll be glad to answer them. Don't forget to like, subscribe, and share. And once again, we are the APS Academic Channel. See you again in our next video.